name's Nicholas Pettit, and today I'm going to be presenting a case illustrating an unusual cause of heart failure in an elderly female, and that unusual cause is a patent ductus arteriosus. A patent ductus arteriosus, also known as a PDA, is a congenital heart defect where a fetal vessel remains patent into an adulthood and is associated with many issues such as pulmonary hypertension and systolic heart failure, and once identified, typically requires treatment. The case that we'll be looking at today is that of an 82-year-old female with a past medical history of pulmonary hypertension, paroxysmal AFib, and systolic heart failure, who presents to the cardiology clinic after a recent hospital admission for a heart failure exacerbation. The patient was hospitalized in March of this year for acute systolic heart failure exacerbation. On an initial exam, she was noted to have bilateral low extremity edema, 2 out of 6 whole systolic murmur, and a wide pulse pressure. She diuresed well on IV Lasix. An echocardiogram was performed, notable for an ejection fraction of 35% and an elevated RVSP at 53. A coronary angiogram was performed, showing no evidence of coronary artery disease. The patient was then started on goal-directed medical therapy for her systolic heart failure with Entresto, spironolactone, and torsemide, and eventually discharged home. On follow-up to the cardiology clinic 3 months later, a repeat echocardiogram was performed, showing an improvement in the ejection fraction of 40%, an RVSP of 44%, and a new finding of turbulent flow within the main pulmonary artery during systole and diastole, concerning for a possible PDA. This continuous flow can be seen in Figure 2 in the center of the poster. After being told about this finding, the patient later recalls being told that she had a congenital heart abnormality earlier in her life, however, it was unable to be repaired. A subsequent CTA of the chest was obtained, as seen below, confirming the presence of a small patent ductus arteriosus. The patient was then referred to interventional cardiology for possible catheter-directed closure of this new finding. Moving to the center of the poster, we can learn more about PDAs. A patent ductus arteriosus arises from the ductus arteriosus, which is a fetal vessel which allows oxygenated blood to bypass the non-functional fetal lungs. At birth, the lungs become functional, and the ductus arteriosus begins to close, and complete closure is typically achieved within the first few weeks of life. When the ductus fails to close, this is referred to as a patent ductus arteriosus. The incidence of PDAs is about 1 in every 2,000 full-term births, and is more common in premature births. PDAs are typically identified and treated during childhood, however can persist into adulthood. When left untreated, a PDA in an adult can cause many health issues, and is associated with a mortality rate of around 1.8% per year. In smaller PDAs, individuals are at risk of endocarditis or endarteritis, while larger PDAs increase your risk of irreversible pulmonary hypertension, as well as risk of congestive heart failure. Interestingly enough, endocarditis prophylaxis is not recommended for individuals with unrepaired PDAs. So when should you be concerned that your patient might have a PDA? Well, PDAs are typically incidentally discovered in 2 ways. 1, on physical exam, and 2, on an echocardiogram. On physical exam, individuals may hear a continuous murmur, best heard at the left upper sternal border, or a diastolic rumble. You may also see a wide pulse pressure due to the increased flow into the pulmonary circuit. Both of these findings were noted on our patient on initial exam. The second way that you can diagnose a PDA is incidentally finding this issue on an echocardiogram. Echocardiograms are actually very good at finding even small PDAs, and are also very good at illustrating some of the side effects that can be seen in an individual with an untreated PDA, such as pulmonary hypertension, as well as left atrial and ventricular enlargement. Using Doppler imaging, you can also estimate the degree of shunting, and even identify extremely small PDAs. Sometimes additional testing is needed, such as a CT angio of the chest or an MRA of the chest. However, this is typically not required for diagnosis, but can be very useful to help define the anatomy and the size of a PDA. Once somebody has a confirmed diagnosis of a PDA, many of these individuals receive right cardiac caths to help quantify the degree of shunting. Once identified, PDAs typically require treatment, and the preferred method of treatment is through catheter-directed measures, typically using coils or closer devices to close the PDA. For large PDAs or those with a difficult anatomy, though, surgical approaches are sometimes preferred. So in summary, a patent ductus arteriosus in an adult is a rare clinical finding that is becoming increasingly common. It is typically incidentally discovered on physical exam or echocardiogram, and is typically associated with many issues, such as irreversible pulmonary hypertension, systolic heart failure, as well as an increased risk of endocarditis and endarteritis. Once identified, repair is typically recommended and is typically achieved through catheter-directed techniques.